we got just a few more hours, and you guys will put another class under your belt, or notch under your belt. I want to go over the questions that I gave you guys from this morning session. So I'll read the question and then give you some there. First of all, let me check. Can everybody hear me? I see a couple of you weren't able to hear me. Okay, good. All right, just wanted to make sure. So the first question this morning was basically, I want to make sure I got all of your things here. All right, so the first question was stimulation of beta-1 receptors by an adrenergic agonist would A, produce vasodilation, B, elevate heart rate, or C, neither. And the correct answer for that would be B. The beta-1 receptor is in the heart. That's the primary site of the beta-1 receptor. So basically, when you stimulate that, you elevate heart rate. We see that norepinephrine, epinephrine, isoproterenol, all of those stimulate beta-1 receptors and elevate heart rate. All right, the second question was blockade of which receptor is used to decrease gastric acid secretion. This is a key point differentiating between histamine 1 and histamine 2. So the first answer was histamine 1. Second answer was histamine 2. So the correct answer is B, histamine 2. The histamine 2 receptor blockers basically are used primarily for reducing gastric acid secretion. We will talk a little bit more about those when we talk about GI drugs. We'll hit them briefly again. The third one, question is, histamine is found in which type of cell? A, erythrocytes, B, leukocytes, C, platelets, D, mast cells. And the correct answer here is D, is mast cells. That we talked about histamine being released from mast cells. Erythrocytes are red blood cells, leukocytes are white blood cells, platelets are thrombocytes, or they're used for clotting. And then the fourth question was, which drug would be more likely to interfere with the metabolism of other drugs? And the answers are diphenhydramine, B, cimetidine, C, chlorpheniramine, and D, epinephrine. And again, that was a big point that I made right before we broke for lunch, is the correct answer would be B, which is cimetidine, okay? And so if you have any questions about any of those, let me know. But again, just very quickly, I'll go through these, repeat them quickly. Stimulation of beta-1 receptors by an adrenergic agonist would elevate heart rate, correct answer B. Second question, blockade of which receptor is used to decrease gastric acid secretion? The correct answer is B, histamine 2. Question number 3, histamine is found in which type of cell? The correct answer is D, mast cells. And question 4, which drug would be more likely to interfere with the metabolism of other drugs? The correct answer is B, cimetidine. And you will have 4 more questions probably in about an hour, hour and a half, probably around 3 o'clock today. And we'll give you about 15 minutes to do those. And then Marissa will post, I think Aiden has already posted the answers on the other questions. Again, keep in mind we threw out one question because it was poorly worded, okay? But these will be posted. I think, Marissa, if you want to post them either first thing in the morning or later tonight, that would be fine, okay? So now let's talk about drugs. We're going to talk about anticoagulant drugs. We started off with, before lunch, and we discussed the things that set up for coagulation. And what we don't want is we don't want excessive clotting to occur. If we have clots, that sets up for emboli, which can be life-threatening. It sets up for blockage, and we can get, for example, blockage in both arteries and veins. So let's talk about a very common one everybody knows. You will most likely not be prescribing this drug, but you may have patients on this drug. Most people that are on heparin are going to be short-term, either hospitalized or home care or something like that. So you just need to be aware of anytime you have a patient on any anticoagulant. One of the things, if you note that there is excessive bleeding, you need to bring that to the attention of whoever's prescribing this, okay? Also, we have had individuals that have attempted to commit suicide by taking overdoses of these drugs. So just be aware of that. So heparin, we do not have an oral form of heparin. So, for example, what we're going to do is we're going to use heparin. Some of you could probably guess some of the uses of heparin, but basically it's used to prevent venous thrombosis, so clots in our veins. It's used to treat people that develop thromboembolism. They actually, very common site is in the legs, especially lower limbs. We also see it when people are starting to have angina, unstable angina, or it looks like it's going into acute myocardial infarction. We'll give them heparin, and that's to try to prevent that. And we also, to prevent a clot, and we also will use heparin to treat arterial thrombosis, so arterial clots. So, and then of course, most people, if you have had a situation where that you've had an IV, many times we're going to use heparin to put into the catheters to prevent the catheters from clotting up. So when we look at heparin, your run-of-the-mill general heparin is a very heterogeneous preparation. Actually, we have heparin molecules in the preparation that range with a molecular weight from 5,000 to 30,000. And so the normal run-of-the-mill heparin is often referred to as unfractionated heparin, meaning that it's a heterogeneous mixture, okay? Now, with this heterogeneous nature, we're going to see that the anticoagulant, it is an effective anticoagulant, but we're going to see that the anticoagulation activity varies, mainly because we have different size heparin molecules. And the way heparin works is it actually is sort of like we call it a catalyzer or catalyst. So what it's going to do, it's going to sort of jumpstart the coagulation process. In particular, your body normally, when it's going to prevent a clot, well, basically what we see is that thrombin is one of the clotting factors. And so what this does is it basically inactivates thrombin. It catalyzes the inactivation of thrombin. So basically it uses the system to sort of jumpstart it. And the way that that is occurring is basically, and notice I don't have a lot of this in red because I'm going to simplify a lot of these mechanisms, because the coagulation pathway, you saw a video showing the coagulation pathway. That just shows you how it works. And I will probably have a couple of videos that show you how heparin is working and how, in particular, warfarin and a couple of these other drugs work. But basically, what you have is that there are some proteases, which are enzymes that that are involved in clotting process. They use basically thrombin, factor 9A, factor 10A. And what normally happens is antithrombin will inhibit this. So part of the anticoagulant system that you have in your body is inhibiting this clotting factor protease. Typically, this is a very slow process, but what happens is in the presence of heparin, heparin actually binds to what's called the antithrombin molecule. And when it binds, the binding of the heparin to antithrombin actually changes the shape of the antithrombin. What it literally does is when it binds to it, it exposes the active site. And what that means is that now you have more parts of the molecule that can interact. And what this in essence does is it accelerates the antithrombin action by over 1,000-fold. So that's how heparin works. It's basically heparin binds to antithrombin. That binding causes a change in the shape of the antithrombin, which exposes more interactive sites or more active sites, and that accelerates the process about 1,000-fold. The antithrombin, and these are reversible bindings, so the antithrombin protease interaction, it releases the heparin, and the heparin then goes and binds another molecule of antithrombin and accelerates that. So that's pretty much how the heparin works. It's going to really, our normal system, which tends to inhibit the clotting process, what it basically does is it accelerates it tremendously. I've already given you the indications of the heparin. Is that a duplicate side? I guess it is. So we do have a couple of duplicate sides here. Yeah. So from that standpoint is that that's how it works. Now, heparin also will bind to several other plasma proteins. Its half-life is relatively short. It's dose dependent. So the higher the dose, the longer the half-life. But one of the key points is that with any of these anticoagulants, I should have had this in red. So, but this is pretty common sense. So one of the things to remember is that if it's an anticoagulant, then one of the side effects can easily be where that we have too much bleeding. So the major complication is basically bleeding. All right. It basically, we get too much heparin there and they have a greater bleed. You'll see that for all of the anticoagulant drugs is all of them. The tendency or the thing we're concerned about is too much bleeding. Okay, now thrombocytes are platelets, okay? And one of the things that heparin can do is it can actually produce a thrombocytopenia. So what a thrombocytopenia is basically it reduces the number of platelets, all right? So if we have less platelets, we have less clotting. And we see in about a fourth of the patients, roughly 25% of patients, that there will be, if we actually measured their thrombocytes, their platelets, we would see there would be a reduction. That basically seems to be transient. So what happens is there's a reduction and then it gradually comes back up. So one of the concerns that we have is, again, when we have reduction in platelets, that is part of the reason that you may have that can sort of contribute to its actions. Fewer platelets means it's harder to clot, but that's not really its main mechanism. We do see that some patients, about a fourth of the patients, will experience a slight reduction in platelets. Okay. Now, when we have somebody on long-term therapy, and what we're defining as long-term therapy is we see greater than 3 months. Obviously, this would be somebody that would have an IV set up, be hospitalized for a long time. We can see some osteoporosis. Potentially, that osteoporosis may occur simply from the standpoint of that it may be due to the effects on the bone marrow, so that there's a reduction of the bone marrow. I'm not exactly sure of what is the exact mechanism, but that's been one thing that's been proposed. So, Jason, your question is thrombocytopenia rebound. If this is not a rebound, what we see is that, so rebound would expect that the thrombocytes would come back at a higher level. No, what you see is that in some people, the number of platelets or thrombocytes go down, but then it comes back up to normal. So it's not an overabundance there. And that can occur while they're on the heparin. Okay, and we're going to talk about a more serious situation with thrombocytopenia in just a minute with heparin. So this is actually while they're on the heparin. All right, now one of the problems is normal heparin, unfractionated heparin, what we refer to as heparin. Basically, it is very heterogeneous. So we do have some variations. It can clot, but it's not as predictable. Excuse me, it can be an anticoagulant. It's not as predictable. Its half-life may vary a little bit. When we have individuals that we really need to watch them closely, we may use a form of heparin, which is called low molecular weight heparin. One of the, I think the trade name that this went by was enoxaparin. And what low molecular weight heparin is, as the name implies, it is a more homogeneous mixture. So what they basically do is sometimes this may be referred to as fractionated heparin. The other heparin may be called unfractionated. This may be referred to as fractionated. So for a lot of the things that we use heparin for, the regular heparin is not a problem. For example, putting it in catheters and things like that. But if we do have someone that we really need to be very careful with, we may go to low molecular weight heparin. It's a little bit more expensive, was more expensive when it first came out, but the main thing is it's a more homogeneous mixture. Being more homogeneous, what we actually see is that the effects are more predictable. The way they do it is they take unfractionated heparin, and then the companies that make this take unfractionated heparin, and basically when they just isolate a more homogeneous mixture. So The range in unfractionated heparin is like from 5 to 30,000. I don't know exactly the range is in low molecular weight heparin, but it's a much narrower range. So it's more homogeneous mixture, and it's involving more of the lower end of the heparin there. The pharmacokinetics, because it is more pure preparation, pharmacokinetics are improved, more predictable. We have reduced protein binding because we've got smaller molecules. So the low molecular weight heparin is really just is a pure form of heparin, and especially when we need to be very, very precise with that. We don't see as much interaction with the platelets. The heparin acts more with that. So one of the things, if we're concerned about the thrombocytopenia, we may want to use the low molecular weight heparin over this. Has a little bit longer half-life. Heparin is about 2 hours. Low molecular weight heparin is about 4 hours. The bioavailability is about 90% versus heparin is 20%. The reason the difference is that with the wide molecular weight in the unfractionated heparin, it'll bind to more proteins. So bottom line is it's longer half-life, more predictable anticoagulant response. That's the two main reasons, less interaction with platelets and proteins. So that is one of the big advantage of the low molecular weight heparin. Now, when we put people on heparin, we need to be aware that with anticoagulants, there is a concern that individuals could start bleeding. We could over-heparinize them. One of the things that they do when they want to monitor somebody with heparin, one of the things, the most common thing is they're just looking for signs of bleeding. Are we getting excessive bruising? Are we getting some bleeding from the nose, around the gums? GI bleeding, things like that. That's one of the first things, and that's one of the things that you would probably notice if you see excessive bruising or if you see, nosebleeds, things like that. That might be a clue that their heparin dose or any anticoagulant may be too much. We're going to expect somebody, even that's being managed properly and everything, they're going to have, if they get bruised, they're going to get a little larger bruises. So, for example, if I'm on heparin, and one of the things that happens is, if I'm not on heparin and I bumped into the desk, I may have a bruise about the size of maybe a dime. If I bump into the desk while I'm on heparin, I may be looking at something the size of a quarter or 50-cent piece. But if, a huge bruise develops, then that might indicate that I may be over heparinized and would possibly need to look to see if we need to lower the dose. There's a couple of things for unfractionated heparin. They may take a blood sample and do a protamine titration. They may measure anti-10A units. That's another way. Low molecular weight heparin, pretty much if we have somebody that has renal impairment, is really obese or pregnant, we might monitor that. And typically what we're going to see is we're going to look for the anti-10A units that you can request that. But again, on both instances, the first thing you look for before any laboratory test is, because you can look at that almost immediately, do we see any excessive bleeding that is occurring? Now, again, with heparin, there's always the potential of toxicity if we over-heparinize somebody. If we're careful about the patients we choose that we're going to use this in, and we control the dosage carefully, and we monitor, one of the things we can monitor is activated partial thromboblastin time. It's a measure of bleeding. Then we can, basically it's monitoring to see if these people are bleeding too much, okay? And we can minimize this by carefully watching the patient, letting the patient know what to look for when we're examining the patient or when we're around the patient, making sure that we look for any signs of excessive bleeding. Again, our biggest concern in most cases are excessive bleeding, okay? You're going to hear this message several times with several of these drugs, okay? Now, let's go back to this thrombocytopenia, okay? I told you earlier that about a fourth of the patients basically will have a thrombocytopenia. Their platelet levels will drop, and then it sort of returns back to normal. But there is a small number of patients which approximately 5% of patients will develop a severe thrombocytopenia. And what we mean happens here is the platelets drop, they drop pretty drastic. And so what seems to happen, what we think is happening is there's an antibody that basically in a small number of these patients, that this antibody is present in these patients. And what it does is that the platelets that are surrounding each other, well, the antibody will act on those other platelets. And so what you get is you can get platelet aggregation and a clot can form. So think of it like this. What's going to happen is in this 5% of patients, the reason the platelet number drops is because the platelets clump. Okay, so if my platelets all clump together, then that's going to reduce the number of platelets that's moving around. But the other thing is when my platelets clump together, I'm in essence forming a clot, and that clot can then form a thromboembolism. So a clot of these platelets basically can then block a blood vessel. So in a small number of patients, and again, it's estimated about 5%, it appears that heparin can interact with the platelets and cause activate an antibody, which causes the platelets to sort of clump to the platelets surrounding them. So we have a clump of platelets that drops our total platelet number down because the free-floating platelets is what we're counting. But when we get that clump of platelets, now we have a clump of blood cells that can then produce a thromboembolism. So one of the things, Najib, so let me answer Jason's question, and then I'll get yours, Najib. All right, number one is that for Jason, the thing is the clinical reason for using the low molecular weight is typically if we are going to, if we have a person that has some sort of clotting disorder and we need to monitor it closely, a little bit closely and be more precise. Somebody that may, for example, we're going to eventually move these people away from this, but for most things we can use regular heparin. But if we have somebody that there's some clotting issues or that we need a longer duration of action and less maybe potential thrombocytopenia, then we would move them to low molecular weight. A lot of times individuals that are coming after having a myocardial infarction or having some sort of procedure, they'll want them on the low molecular weight heparin so they can just have a better or a closer component of being able to have less interactions with the heparin. And Najib, the low molecular weight heparin, you don't really have to require the monitor on it, but you do look for signs of excessive bleeding. Now, before I go to the next slide, because I think this carries on the next slide, I'll talk about this. One of the things that we run into is that we're giving heparin, whether it's low molecular weight or regular heparin, basically what we're going to do is we're trying to prevent a thromboembolism. But here is a situation where the drug may actually cause the thromboembolism. Najib, with regard to the APTT, that is usually going to be monitored, INR and so forth. Those are normally going to be run routinely. But again, you would have more of a variation of response with the unfractionated heparin versus the low molecular. Typically, the response is more predictable, and only people with renal problems, obesity, or pregnancy we may have to monitor that a little bit closer, and we may do that more so in those patients. So one of the things that we see is that this gets to some of your questions, Najib, also. So one of the things we're concerned about is toxicity. So in every patient that's given heparin, we're going to always be aware to make sure that we're not seeing excessive bleeding. But with heparin, one of the things we should be doing is platelet counts, because we want to make sure that none of our patients happen to fall into that 5% that's going to produce that. If we see a thrombocytopenia when somebody is on heparin, we basically consider that heparin may be causing that thrombocytopenia. Also, if a new clot forms, a new thrombus forms while they're on heparin, that would suggest, or we have to be aware that basically that new clot that formed, you have to consider two things. One, did it clot because of the pathology that we had, or did the heparin cause the clot? And so if there's any reason we think that there's a thromboembolism that may be due to heparin, then we need to discontinue the heparin, okay? The fractionated heparin is more predictable. Low molecular weight heparin is more predictable because it is not as varied with regard to that. So the side effects of low molecular weight heparin tend to be less than what we see with heparin, okay? So a big thing is if someone's on heparin and they develop a clot, one of the things we need to consider is that the heparin causing the clot? Because the worst thing we can do is give them more heparin, which if the heparin's causing it, that's going to just accentuate the potential for the clots. Now, when do we not give heparin? And this is going to be similar for most anticoagulants. Any drug, the contraindication is somebody's hypersensitive to it, okay? But if they have active bleeding, you don't want to give heparin because if they are actively bleeding, that's going to make the bleeding worse, okay? But other things we look for is somebody with hemophilia, they're prone to bleeding. Someone that has already a significant thrombocytopenia because heparin can make that worse. Purpura is, what is purpura? Does anybody remember what that is? Purpura would be bleeding or bruising and things like that. Arnold, we'll pass that on to you from a standpoint to see if we can fix that. I know Judy has been working with that, but I'll pass that on to her. People with severe hypertension, you don't want to put them on heparin because one of the things would happen is the high blood pressure could blow a blood vessel, and with heparin they would bleed out or could have extensive bleeding. GI ulcers, that would make the bleeding worse. Advanced renal or hepatic disease would mean that the drug may not be broken down and we could get accumulation of that. We do not have an oral form of heparin, so it's got to be administered parenterally. Typically, it's going to be given IV, usually as a continuous IV dosage. If we're giving it intermittent, like injections every now and then we want to measure to see sort of what the clotting is done. You don't want to give it intramuscularly. If you hit a blood vessel down in the muscle, it can produce a hematoma. Sometimes people will give it sub-Q, and that can be a problem. It can work sometimes, but you always have to be careful about bleeding if giving it sub-Q. So what happens if we need to stop the heparin? The person starts bleeding or we get the thrombocytopenia. First thing, stop the drug, okay? Now, one of the things which seems so common sense, but I have seen this happen numerous times. I've been involved in law cases where this has come up and you just wonder what's happening. Sometimes when people have things that start developing, someone forgets to stop giving the drug. I have seen people that are having very significant bleeds, and it's like someone thought someone else was discontinuing the drug. So one of the things is, most of the time when we are dealing with an overdose of heparin or heparin toxicity, a lot of times by simply discontinuing the drug, stopping the drug, if they're not bleeding too much, we just watch them and the drug wears off, and that's all we have to do. Okay? Now, let's say we have somebody that we've got some significant bleeding that's occurring and we don't really have time to stop to wait for the drug to wear off, okay? Remember, the half-life of heparin is only about, unfractionated heparin is about 2 hours, fractionated heparin is about 4 hours. So, or let's say we gave too large of a dose and we need to correct it quickly. There's a drug called protamine sulfate. And what protamine sulfate does is it actually will bind to the heparin. And when it binds to the heparin, that prevents the heparin from binding to the antithrombin, okay? Now, we have to be careful when you give protamine sulfate. If you get protamine by itself, it can actually have an anticoagulant effect, okay? So we limit how much we give. We don't give more than 50 milligrams in any more than, I mean, in a 10-minute period, we never give more than 50 milligrams. Now, interestingly, protamine sulfate works pretty well on the unfractionated heparin, but it is not completely effective on the low molecular weight heparin. And it's just dealing with how it binds. So apparently, I think it binds to the larger proteins a lot easier. But protamine will reverse and neutralize heparin. But protamine will, even though it may reduce the effects of heparin, it will not completely neutralize low molecular weight heparin. So heparin is, we see used, but the biggest issue is going to be, and it works well, it has a few problems just like every other drug, but you know, fact is a lot of times if you get a little bit too much, stop it. That's all we have to do. If we get too much, protamine sulfate works pretty well. Get a little bit more predictable response with the low molecular weight. But here's the problem. Heparin has to be given parenterally. We're going to either see it given IV, excuse me, or sometimes with the low molecular weight, it'll be given sub-Q. But what about people that we need long-term control on? Okay. Excuse me. So with long-term control, we need an oral anticoagulant. And so there's been several oral anticoagulants that have been developed. We're going to spend most of the time talking about this one right up here. A couple of reasons. This is one of those, remember we talked about these steep dose response curves. Warfarin is one of these drugs that is a steep dose response curve. We're going to see there's a lot of people that are on warfarin. When do we see warfarin? We've seen other drugs like dicumarol, phenandione, vitamin K1, which is phytonadione. All of those have been tried, and it is, let's see. So, but warfarin has until recently been the go-to drug. The other drugs just have not given us the advantage and efficacy that we've seen with that. So that is a that is going to be one of the big things. So warfarin, sometimes it was referred to as Coumadin or warfarin. This one is going to, the way it acts, and I think I've got two videos when we take our next, sometime this afternoon, I'll put those videos up that'll show you an animation of how this works. So what warfarin does is it interacts with prothrombin factors 7, 9, and 10, and also anticoagulant protein C and S. So it interacts with a number of places. And what it's going to do is it's going to actually bind to the glutamate residues of those factors there. So when it binds to those components, those molecules, it inactivates them. So it's basically interacting with prothrombin factors 7, 9, and 10, and factors protein C and S. And by making them inactive, basically what it does, it inhibits coagulation. The other thing about warfarin is that it interferes with vitamin K, and I should have had this probably in red, but I've mentioned it. We talk about vitamin K in a few minutes, but vitamin K these are vitamin K dependent. It's warfarin is interacting with these factors that are vitamin K dependent. The new drugs that have come out, what they refer to as NOACs, the new oral anticoagulant drugs, are vitamin K independent. The reason that is important, as you will see in a few moments, is that dietary intake of vitamin K can affect warfarin levels or warfarin's activity. And sometimes that creates a problem. Now, one of the reasons why you need to know about warfarin is that it has a large number of drug interactions. Has a steep dose response curve, so it doesn't take much change in concentration of the drug to produce toxic effects. And one of the things that we deal with is that it's a very highly protein-bound drug, which means that other highly bound protein drugs can produce an interaction, and they can bump warfarin off the things like albumin, which suddenly makes more free warfarin, which can then kick someone into where they have a situation of bleeding. It's got a long half-life. That's good and bad. Long half-life means that, basically when we have a long half-life is we don't have to dose as frequently, but it also means it takes longer to get out of our system. When you start warfarin, you've got a delay in when you actually will see the onset. Typically, it's about 8 to 12 hours. So a lot of times if someone's in the hospital and they've been on heparin and now we're moving them out of the hospital, so we need some sort of anticoagulant, we're going to have to basically transition them from heparin to warfarin. So there is a period of, it's anticipated roughly several, about a day to 2 or 3 days where that we have to sort of overlap. Part of it is due to the delay in onset of the warfarin's actions. The reason for this is because there appears to be, early on, there's just this partially inhibited synthesis, and there's a degradation of vitamin K dependent clotting factors. As those things are occurring, it takes a little while for it to occur in. So if we stop the heparin and put somebody immediately on warfarin, we would have a period there where remember heparin's got a short half-life. So when we stopped heparin and started the warfarin, one of the things would be is there would be a period where that the individuals would be very susceptible to thrombus forming from that standpoint. So when do we use warfarin? This is one of the ones that we're constantly using for, we like to use this one for either prevention or the treatment of clots or emboli. So we use it for venous thrombosis, clots in the veins, or the extensions where we may get break-offs and other emboli that may occur. Pulmonary embolism, very common thing is somebody's had a pulmonary embolism, or we try to prevent it by, if they've got venous clots, in their legs, what we're going to do is try to put them on warfarin. And probably one of the biggest things, and you starting to hear a lot about it with this advertisement of these new anticoagulants, is atrial fibrillation. Atrial fibrillation is one of the big things that's in the news and the media now. What happens with atrial fibrillation is the atria are basically fibrillating. So basically they're just they're not pumping really regularly, very regular. Most of the time we don't need our atria to pump the blood. I mean, when the atria pump, basically when the valves open up, probably 95% of the blood falls by gravity from the atria into the ventricles. When we exercise, we see that the atrial pump probably helps a little bit, gives it a little extra kick there. But people can live with atrial fibrillation, but because the atria is not really pumping, there are areas that the blood becomes, can just sort of pool and stay there. And what happens is that blood stasis can set up for a clot. So then what's going to happen is if a clot forms in the atria and it breaks off, or a portion of it breaks off, it'll go, and it will go, depending on where it's at, if it's in the right atria, that clot will form a pulmonary embolus because it'll leave the right ventricle and go into the lungs. So we can get a pulmonary embolus there. If it's in the left atria, then that can go up and produce a clot up and have a stroke. So also when people have valve replacements, whether they're using mechanical valves or pig or cow valves, when they put those in, those valves can have a potential for forming clots on those. So atrial fibrillation and valve replacement, most of the time we have people on anticoagulants to basically send it in to the send it up to perform an embolus. Okay. We also use this after a myocardial infarction. It prevents risk of death. It prevents a recurrent, helps prevent recurrent because it's preventing a clot from forming. And so there's a lot of reasons we use it when we have either a high risk for clots, or we have we've already had a situation where a clot has occurred. All right. Now, the major adverse effect, just like with heparin, the major adverse event is hemorrhage. Okay. Things that influence the risk of bleeds. Okay. Warfarin, if there's a lot of different things that can cause this. What I usually try to tell people is if you are going to write a prescription, and you guys should not be writing to, basically writing in prescriptions for warfarin, but you will have patients on warfarin. But one thing, if we look at what can be put a person at a risk factor, I always tell people, if you have patients on warfarin, let a warfarin clinic manage them. They have pharmacists there that are very familiar. They can closely monitor. They can help educate the patients. So one of the things is the intensity of anticoagulation. That translates to what's the dose. How often are they taking it, and what dose are they taking it? Another thing is that there are concomitant clinical disorders. And so the concomitant clinical disorders, basically anything that may set up for example, if you have, have had a stroke, or if you've had a heart attack and things like that. Those are issues that are there. Other medicines, because they can interact with with this. And then when I say quality of management, who is monitoring these patients? What type of monitoring is being done? Warfarin will cross the placenta, and it can be teratogenic. So we're not going to use warfarin in women that possibly are pregnant or are pregnant. During pregnancy, if we have to use an anticoagulant, we will try to use heparin. Older people, we see that there is a greater chance of bleeds in older people. Number one is that as you get older, you're more sensitive to most drugs, including warfarin. Many older people have a lot of comorbidities. What we find is there's an increased drug interactions because in older people we see that. When we see, Kara, you're talking about using warfarin in kids. We will see that those warfarin can be used in kids. Again, it's got to be watched carefully and monitored. So, for example, that's one of the concerns, Kara, is that basically that kids are very active. They're very prone to possibly falling down and that sort of thing. So what you try to do is you try to keep the warfarin levels as low as possible. But for example, a child that would have a heart valve replacement would be the most thing that I could see. That would be the biggest concern. So that would have to be kids being very, very active are going to be prone to fall down and bleed. So what we have to do is we sometimes limit their activity or monitor their activity, and we keep the heparin down, or the warfarin down extremely low, where it's just at the therapeutic range. But that is a big issue there. And also, as Carrie just said, is that the again with warfarin is one of the things that we see is that the vitamin K. So we have to monitor their vitamin K intake. So their diet has to be a very important situation that has to be taken in. A lot of education of the parents. Just to give you an example, with kids, with adults, pretty much there are certain guidelines that are put out that give you the protocols, and there are those guidelines for pediatric dosing that is different there also. So we're using for infants and children, we're going to use a much lower dose. From a standpoint of Sherry, the thing is, with regard to pregnancy, we're concerned about teratogenesis, but with nursing, you could see a potential of the anticoagulant going across in the milk, and there would not be a birth defect issue, but you would be, if you saw any excessive bleeding or things like that, that would be something that that you would consider. I was looking at there, according to, I'm just pulling up Hippocrates, that it can be used for breastfeeding. There is no known risk of infant harm, but you would just look to see if there was potential increased bleeding with the infant. That would be the concern that you would have. All right. Let me cover this. I want to talk about this monitoring for warfarin. And we touched on this before, but we'll do this and then we're going to take our break. So here we have is that when we're monitoring warfarin, it's very important that we monitor warfarin because of its narrow dose response curve, very steep narrow dose response curve. So typically what we used was for monitoring warfarin, and we're going to do this on any warfarin patient, is we used to ask for a prothrombin time. We talked about this when we talked about lab values in physical assessment. So typically what we used for measuring bleeding was prothrombin time. But what happened is that it was discovered that there was a lot of variation. The reagents that they use for measuring prothrombin time, they varied quite a bit. They varied significantly so that if you were measuring it in one hospital or one lab, you couldn't rely on that on another lab, in another lab, because of the variability. Even if you measured it in the same lab and you went back 6, 9, 12 months later, you couldn't be guaranteed that the prothrombin time was compatible. So what occurred was and we also have changed because we used much higher intensity for warfarin. And so now we've moved more to low intensity to get at some of the issues that you guys have been talking about. What we're trying to do is use the lowest dose possible that we get the anticoagulant effect. So we're moved way down on that, and we'll see why in just a little bit. So what came about is, how do we normalize this? And they came up with a system called the International Normalized Ratio. If you request a prothrombin time now through a lab, they're going to send you an INR, okay? So what this INR is, and again, I think you guys have seen this, it's really a mathematical correction of the PT ratio, okay? It takes into account that the thromboplastin reagents may differ in their sensitivity. And so what they have is a reference thromboplastins, and they know exactly what that activity is, and they compare and rate all other thromboplastins with that. And so they come up with the international normalized ratio. And the big thing is this allows for comparison of results between labs. So let's say the person had one done when they lived in Jacksonville, Florida, and now they've moved up to Atlanta, Georgia. That means that the lab that's done in Atlanta, Georgia will be comparable. So it standardizes the reporting of these prothrombin times. So here's an example of, and again, I think I showed this to you when we talked about physical assessment. So here we have a single blood sample, and we measured PT using 5 different thromboplastin reagents. So you see here, thromboplastin reagent A measured from this blood gave us a prothrombin time of 16 seconds. Whereas down here, if we use thromboplastin E from the same blood sample and use the same blood sample, it gave us a prothrombin time of 38 seconds. Big variation, okay? So what happened is that if you actually normalized it, what you see is that using these different thromboplastin reagents gave us different prothrombin times. But when we normalized it, you see that here we had a range from 16 to 38, which would be hard pressed if this was measured in Jacksonville, like I said, you had 16, and then you came up to Atlanta and was measured 38. Who knows what it would be if you went over to Birmingham, if the patient went over there. But by using the INR, basically we see that if we standardize these thromboplastin reagents by their INR, that this from the same blood, we would expect the same result. And that's what we get with the INR. But from the same blood getting a range from 16 to 38, depending on which thromboplastin reagent we used, made it very difficult to really monitor and keep therapy. So we started using the INR for that. And so what we're doing here is basically that gives us a standard by which we can monitor that. And that's what we're going to use as we're monitoring for whether the warfarin is in the right range or not. Now, as I mentioned earlier, I'm going to do this slide and then we're going to take our break. So what's happening here is basically, let's say we've got somebody in the hospital, they're on heparin, we're going to move them to, they're moving outpatient or going home, but we need them on an anticoagulant. So what we may start is that we've got them on the heparin. So what we might start doing is a day or two before we're going to plan to release them, we may start giving them warfarin. So one of the things that we see is that it's hard to measure in the transition. The INR may not be accurate in that first transition. So basically what happens is we give them heparin, we overlap with warfarin, and we watch for the bleeding because we want to make sure we don't get too much bleeding. And basically what happens is when we get the INR up to the therapeutic range, we start after 4 days, then basically we discontinue the heparin and we should be fine there. So that's an overlap that occurs. So you may see a patient on heparin and warfarin, especially when they've just come out of hospital. Okay. All right, let's take our break and let's see. Let's come back at 10 after the hour. And then we're going to talk more about warfarin and some of these other type things. Marissa, one of the things, if you might set up the last 4 questions, and we may go for those. Let's see, it's almost 2. We may take that other part of that test maybe around 3 or 3:15. So you might set up that, and then also don't forget to take the attendance poll. So I will see you guys at 10 after the hour. All right, guys, let's go ahead and pick up where we left off here. And so the contraindications to warfarin therapy really is going to be situation with this is pregnancy, obviously, because as we mentioned before, there is the teratogenic effect. And really, when somebody is prescribing warfarin, the benefit risk, which anytime you guys are going to prescribe a drug, you need to be making a benefit risk assessment, which means is the drug that I'm going to use going to provide more benefit than harm. So one of the things really comes into play is that when we are prescribing warfarin is basically we have to determine is the anticoagulant effect worth the risk for bleeding. Now, one couple of groups of patients that this is sometimes difficult is, for example, people that have uncontrolled alcohol or drug abuse. Warfarin is going to be, I mean, this is not going to be one of these things where they can, take it if they want to, not take it if they want to, or try to double up on doses. So that's a concern. The other group of patients that you may see would be those that are unsupervised, that have dementia or psychosis. Missing medications can create a problem. Taking too much can create a problem. In both of these patients, one of the things that we run into is the possibility of someone trying to commit suicide. And taking warfarin is basically, and can do that. They can end up with a severe intracranial bleed and or stroke, and that can occur. Now, one other thing I want to mention to you, this deals with warfarin, this deals with a lot of others. Years ago, I had a case where that we had a woman that basically was that had a cocaine problem, and she was also had a heart problem, sort of an unusual not an unusual, sort of a weird situation. So somebody's doing cocaine, but at the same time has some severe heart problems. I can't remember if she had a valve replacement or if she had atrial fibrillation, but she was doing cocaine and she was on warfarin. And her psychiatrist basically checked her into a hospital, one of the local hospitals in South Georgia, to detox her and get her in for rehabilitation. The psychiatrist, when he checked it or admitted her into the hospital, went continue all meds. So what happened in the hospital, we started seeing that her INR going way up, and the hospital was notifying the psychiatrist who was ignoring the INR. The woman ended up having a stroke and died, and the psychiatrist was sued. Well, the psychiatrist's argument was that he is a psychiatrist, that he did not prescribe warfarin. That was her cardiologist that did that, or her family practitioner. And since he didn't prescribe it, he was not responsible for it. But what he forgot was when he admitted her and he put continued all meds, he then became the prescriber. So one of the things is when you are dealing with patients and you are seeing that they're either being discharged or, changing institutions or whatever, is one thing you just may be aware of is that if they are on warfarin, that, this is an issue, especially if they're in one of these patient groups that you guys might typically see. So that's going to be one of the things that you guys just need to be aware of. But again, anytime you're prescribing drugs and you have a patient that is on warfarin, you need to be aware of that, because that needs to factor into your benefit risk, and you need to factor in, for example, if your drug is highly protein bound, it may be a situation where you might want to have to look for another drug that has low protein binding. So that's just something to be aware of. Now, here is one of the things that we see. We have changed primarily to what is called low intensity treatment. Okay. So low intensity treatment basically means that we're going to give the lowest dose where we will get the benefit and try to avoid the side effects. So there's a couple of things that you need to be aware of. So one is that the range typically for most conditions with warfarin, we look at an INR we try to keep their INR somewhere between 2 and 4. Now, certain doctors will want to keep it between 2.5 and 3.5. There's certain guidelines that'll say what they should use the target. What we do know is that if the INR drops below 2, we do know that there is a significant reduction in efficacy. And if it drops below 1.5, we do know that it doesn't work, okay? So people that are missing their drug or not taking their drug, what can happen is that INR can drop down and get below to the point where it's ineffective, and they may be, so it's one of these drugs that it's damn if you do, damn if you don't. If you go below the INR, then you lose the efficacy and you're at risk for clots. If you go above the INR, then basically what you see, you're at risk for bleeding. So typically we see that at an INR above 4 is that we start seeing that there is when we go above 4, there's an increase of a risk there. So this is sort of emphasizing this point. So what we have here is, this was a study that came out in '94. So the green area, this is where we tend to target, is between 2 to about 3.5. But if you can see is that where this line is that we basically see that the odds ratio, is basically considered acceptable between 2 and 3, okay? But when you start getting above 4, you start seeing that big jump. So when we get above 4, we start seeing the odds ratio getting up around your chances. So basically the chance of bleeding goes way up, and especially when we get up around 4.95, we've got the odds ratio of having an intracranial hemorrhage goes up to 11.2, and when we're up above 6, 18.2. The lady I was telling you about with the cocaine and that sort of thing, her INR was even higher than this. So the point becomes is that when we start getting above 3.5 to 4, then the odds ratio or the chance of bleeding starts moving up where it's almost unacceptable. On the other hand, what we find, this is from the same study, I think it was the same study if I'm not mistaken, different same group, but a different study reported. And what we find is that when it drops below 2, basically the chance of clotting is going to be at a higher risk. So you see over here, when you start going to 2, the chance of a stroke or a clot in atrial fib patients starts going up. When it's down, 1.5, we start seeing the big upswing around 1.5, and then below 1.5, it's pretty much considered ineffective. So what we're trying to do is, again, most docs will try to keep the INR somewhere between. Typically, what I see is somewhere between 2.5 to 3.5. But you may see sometimes some docs will go down to 2. Some docs may go up to 3.5 to 4. Most of them are going to stay between 2.5 to 3.5 for most conditions. So again, if your INR is too low, it means that you're at risk for clots. If it's too high, you're at risk for bleeds. There's a lot of different things. Basically, you're dealing with warfarin, which has a narrow therapeutic index, which means it doesn't take much of a change to have a big change in the effects. So we have to really look at patient disease state. What are the comorbidities? What is the patient? And then the process of care. Who's monitoring? Who's monitoring the administration of the drug? Who's monitoring the INR? One of the things that happens is, what if the INR goes too low, or what if the INR, typically what we see a lot of times is the INR gets too high, and then someone needs to make literally needs to start looking at, what's going on here. So what will happen is sometimes if the INR creeps up, what they may do is they may say, skip a dose. And so if you're taking 5 milligrams, then every day, then drop don't skip a dose and take the 5 milligrams the next day to see if the INR is, so you skip one day's dose, then take the 5 milligrams, or maybe they'll take half the dose. So the people that run warfarin clinics can do this pretty precisely. they have a good idea of how much of an adjustment is necessary. This is a drug that you don't want to double up on dosage with. So if you forget your warfarin, you're not going to want to, you don't want the patient to double up. Now, there have been, in fact, one of the videos I've got for you guys a little bit later on today, this afternoon, is the 50. It's called the 50 years of trying to move away from warfarin. So it talks about various different anticoagulants there. But for a long time, because of the issue that we've had with warfarin, one of the things is people have tried to use try to come up with different drugs. So what we found is that the other drugs that they've looked at, for the most part, have had concerns that either their pharmacokinetics, meaning that how long, their duration of action, their onset of action, and so forth, was unfavorable, or the drugs may have even been more toxic, had more problems. Dicumarol was one that's been used occasionally, but it doesn't get absorbed completely, has created some GI problems. Phenandione is one that people tried to use. They had some liver and kidney problems with. So warfarin has really been sort of the mainstay of therapy for individuals that are taking, that have atrial fibrillation, or we're using for, that we need for an anticoagulant. Now, let me throw one other variable that comes into play here that sometimes people argue. Jason, let me answer your question. So the INR is monitored really because, like you said, if the INR drops below 2, the risk of clotting, so developing a stroke, developing a thrombus or whatever, starts going up. If it drops below 1.5, basically it's considered not even working. And when it gets too high, typically when it starts getting above 4. So most of the time they're going to try to keep it. Most guidelines, depending on the particular patient and condition being treated, typically they're going to want it somewhere between 2 and 4. Different guidelines, American Cardiology, different types of organizations have made different guidelines where they may say somebody that was an artificial valve, they may want on between 2.5 and 3.5. So different things have suggested, but typically they will fall between 2 and 4. Okay. And again, we're going to monitor the INR more carefully. What I was going to say is one of the other little things that creates a problem is most warfarin is, all warfarin that I'm aware of now is generic. And what creates a problem is that there's not just one generic, there are multiple generics, which means that we remember when we talked about generic drugs, one of the things that we saw is that there may be some variation, even though they're all supposed to be evaluated or compared to and meet the standards of the RLD. So when you look at the different warfarins, so basically I just pulled up on Hippocrates, and the 1 milligram warfarin dosage, that right now there's 5 different generics that have a 1 milligram. Now all of those are pink. Okay, so they've tried to sort of keep them, but they're different shades of pink. The 10 milligram tablets, we've got, let's see, 1, 2, 3, 5 different 10 milligram tablets. 3 of them are sort of elliptical. 1 of them is round, and then 1 of them is more of a, one is really elliptical, and there's 3 of them that more look like sort of elongated eggs. 2 of them look sort of a yellowish hue. The other 3 dosages are all white. At the 2 milligram tablet, there's again, I think 5. We have 2 of them that, 3 of them that are elliptical. 1 is lozenge shaped, that would be a better term. And they're between pink, sort of a off-white to a purple. At the 2.5 milligrams, they look mostly green, different shades of green. Fewer, I think there's 1, 2, 3, 4 of those. Warfarin tablets at 3 milligrams. We've got another 5 tablets, and they go from yellow to flesh colored. The 4 milligram tablets all are blue. One is turquoise, but different shapes. So what I'm saying is that we have multiple manufacturers, multiple generics, and as a result of that, there may be some variability. Most people would think, okay, if we put them on a generic and they stay on that generic, then they should be okay. But you never know that when wherever you're getting them from may change their supplier. So that's an issue that comes into play. Some people argue that generic warfarin, they would prefer that there be, that there be only one and the person stays on generic. When the name brand was out, what people preferred would be to try to go with the name brand. So from that standpoint, that is another concern that's come up, is people that may be getting different generics could potentially have a problem there. And so if you look at the black box for warfarin, it says bleeding risk, major or fatal bleeding, starting period with the higher dose, or when you're using high intensity anticoagulation, patients 65 years and older, when there's a highly variable INR, if they have any GI bleeding, hypertension, these are all concerns that they have. And it talks about that if you have issues that you may want to do more frequent INR. So there is a lot of things, and one of the things that because of all these variables, is one of the main reasons why I suggest to people that are putting patients on warfarin that they do that with basically in a scenario where that you have a warfarin clinic being monitoring that. But again, because of all the problems with warfarin, because of it being a very narrow therapeutic index, there have been attempts to try to move to other anticoagulants, okay, and to get around them. So what happens if we get too much of a bleed? And I've seen this. Sometimes if we just see bleeding or potential for a bleed, or maybe their INR has gone up, we may discontinue the drug. Of course, when we discontinue the drug, one of the concerns is going to be as the warfarin wears off, we're going to be potentially at a higher risk for clotting. So we got to watch for that. If we have maybe the INR has gotten really up there and we're concerned about intracranial bleed, one of the things that we may do is give vitamin K. Vitamin K is an antidote. And so administering vitamin K because warfarin interferes with vitamin K. And so if we add vitamin K, then that helps get rid of it. We can also give fresh frozen plasma or prothrombin complex concentrates or recombinant factor 7A. These are all components that the warfarin has inhibited, so we can replace those. But if we do have a severe bleed, we may be using vitamin K plus the plasma and the other stuff that's there too. So it's on, it varies from, I've seen all instances being used. The worst situation is when somebody doesn't do anything and there's significant bleeds or in a high risk of bleeding, and then somebody has an intracranial bleed. The other thing with warfarin, I want to mention this too, is one of the big things is that if you do have an elevation, we want to figure out what happened. Is it a drug interaction? So we want to look at their medication history. Is it sometimes people have changed their diet so that they're taking in more vitamin K? We get vitamin K from green leafy vegetables. So sometimes it can be a diet change. Sometimes it can be a drug interaction. Sometimes it can be a medication error. So that I have seen where that a error has made in prescribing or in filling the prescription. But and the other thing would be whether the individual may have, especially with older people or people that may have certain caregivers, they may mix up their pills and so may have taken, 2 warfarin tablets instead of taking 2 of their antihypertensive meds or something like that. So we handle the bleeding situation first, and then what we do is we try to figure out what has happened. If by some chance their liver, kidney function is altered, or we have some sort of something going on, protein binding issues or whatever. So for example, if someone had something where their plasma proteins went down, that would mean that the dose that we were giving, we're getting too much of the free drug that's kicking in. All right, let's go to the next. All right, so let's look at a few other anticoagulants. Move through some of these fairly quickly. Aspirin. Aspirin is a not as many people take aspirin as they did before. Used to, aspirin was our main pain analgesic. What aspirin does is it blocks the prostaglandin synthesis, specifically by inhibiting cyclooxygenase. What that does is that prevents thromboxane A2 being formed, and thromboxane A2 is what causes coagulation. And when that blocks it in the platelets, basically that can last for 7 to 10 days because the platelet can't redo it. It also blocks the formation of prostacyclin, which is actually an anticoagulant. But the difference is that the prostacyclin is formed in the endothelial cells, and the endothelial cells can replace the prostacyclin. So the reason aspirin is an anticoagulant is primarily because of its effect on the platelet thromboxane, which can't be replaced. And even though it blocks prostacyclin, which is an anticoagulant, that's replaced, so that is not a big issue. Aspirin absorbed very rapidly from the GI tract, typically in your blood in 5 to 30 minutes. Peak concentrations within an hour. Aspirin basically will prevent or inhibit coagulation for about 36 hours. So we're looking at about a day and a half. So what you're looking at here is a lot of times before surgeries, they want you off the aspirin 2 to 3 days issue there. I'm reading your question there, Jason. Let's see, can these drugs at too high a constant dose? No, so it's a good question because we refer to these as blood thinners. And it's not a situation where that it just simply leaks through the blood vessel walls, because one is what's going to happen is that the platelets and everything like that, those are going to not get smaller. What you're going to do is that the platelets are not going to coagulate. So we use them as blood thinners because we think of when things clot that the blood gets thicker, or when you think seeing blood clot, you see it slow down and sort of gets quicker, gets thicker. But what happens is that it makes it throughout the day. You do a number of things in which you increased activity may result in a slight rupture of blood vessels like the capillaries. So what can happen is that basically it doesn't take much of a tear or something that occurs in a blood vessel. For example, if you sneezed really hard, you can sometimes break a blood vessel in your eye. Even just getting up and moving quickly. I mean, I've done that before. So when you do activity, your blood pressure can go up. And if your blood pressure goes up and causes a weakness in the blood vessel wall where the pressure goes up and basically ruptures that, then you get a hard bleed. So what you can get is that because of increases in blood pressure that occur during your normal activity, that can cause it to rupture. So it's not that the blood just simply becomes so thin it leaks through the walls, because the capillaries are, in some areas they're a little bit thicker, tighter than in other areas. But it's basically the normal breakdown. So it's the normal, hold on one second, guys. Sorry, guys, that was Barney being a little wacko. So the biggest thing is that when you do activities is that you can get blood pressure go up, which can then cause the blood vessels to break. Normally, your body will handle that, but with the anticoagulant, you don't have anything to clot, so you get more of the bleed. So in a way, it does get leaky, but it's not simply going through there. It's basically due to a minor rupture of the blood vessel. Now, typically what we see aspirin is a lot of people, I don't know if any of you guys have ever taken aspirin for a headache or anything like that. We see there's very few people. When I was growing up, as a child, you got Johnson's baby aspirins, which were little orange um, St. Joseph's baby aspirins. They were called because they were 81 milligrams, so they were smaller. And they were orange flavored, so you could give it to infants. But with Reye's syndrome that can occur, children never get aspirin anymore. What we do see is St. Joseph's actually has changed their label from stating baby aspirin. They've changed their label basically to read St. Joseph's heart aspirin or heart formulation, something like that. So typically what we see is that people that are needing coagulation, anticoagulation, is 81 milligrams. And Eddie, the thing about it is, which is interesting, is basically is 81 milligrams is a low dose, but there are people that can have significant bleeding that occurs there. And when people have had like stents and things like that, we see sometimes the issue is pretty much going to be that they are going to they will go up to 325 milligrams for a while, but they ultimately drop them back down to 81. Kirsten, I am not sure about that. When we take our break, I'll see if I can find if there's a mechanism. My thinking is it may interfere with the blood supply there, but through the prostaglandin mechanism. So the biggest thing with aspirin, we've got bleeds. That's going to be a concern. But another thing, even at low doses, the 81 milligrams, we can get some GI irritation. A big concern is gastric ulcers. And what we found is why aspirin is used is we have found that it is, the data suggests that it prevents recurrent heart attacks, and it also reduces mortality. There was a study that just came out this last week, which said if you're normally healthy, there's no benefit for taking aspirin. Another thing aspirin is used for is for TIAs. It seems to, if people have transient ischemic attacks, it can be used. And we see aspirin a lot of times being combined with an anticoagulant. The big flag on aspirin was Reye's syndrome, which is an encephalopathy. And with Reye's syndrome, basically, that's why we quit using it in children. Children that have a virus, if they're given aspirin, may be at risk for developing Reye's syndrome. It's rare, but it can still occur. Okay. Now, a couple of these other drugs. And by the way, aspirin a lot of times, especially when somebody has had a stroke or has had a heart attack, a lot of times they will be given aspirin and one or two other drugs. It's not uncommon for them to be on I've seen what is called triple therapy, which is Lovenox, aspirin, and usually something like Plavix or clopidogrel, which we'll mention in a moment. And Marissa, I'll just tell you now, if you want to set up the poll for the next 4 questions, we'll do that in probably 7 or 8 minutes. Okay, and we'll give about 15 minutes for those. Ticlopidine is another one of these anticoagulants. I don't have anything in red here. I've just mentioned it to you. Basically, what it does is it prevents platelets from sticking together. It also prevents the platelets from binding to the fibrinogen, which is the scaffolding I told you about. It's orally effective. It takes about 4 days for it to kick in. We find that people have renal problems. You don't like to use this because it accumulates, so that can cause, we have to reduce the dose. It's actually better than aspirin in many cases, but one of the problems that we see is that it can produce a neutropenia, so you lose white blood cells, and it can also produce what is called agranulocytosis, which means that your blood marrow may not be able to make cells. So what ticlopidine is used for is sometimes patients who can't tolerate aspirin or who are unresponsive to aspirin, then ticlopidine can be used sometimes. That may be an alternative. The biggest things that we see is that a lot of patients will complain of it, causes them to have indigestion, some dyspepsia, maybe a little nausea. But during the first 3 months, you can develop a leukopenia, which means that your white blood cells go down, so you could be susceptible to infections. So what they typically will do is if they put somebody on taclodipine for the first 3 months, they're basically going to monitor white blood cell counts. One of the big things that we see with some of these anticoagulants is called thrombotic thrombocytopenia purpura, TTP. Basically, this can create a clot, and it's the same thing we talked about with heparin. And this can be significant. So with anticoagulants that interfere with platelets, this can occur. So if we see a thrombus start forming, it could be due to this drug, and we have to be careful with that. Try to keep the dosage low to minimize the side effects that's there. But diclodipine, basically, what we've seen is a drug called Plavix, which is clopidogrel. This drug actually has been used more frequently than diclodipine. You don't get the neutropenia to the same degree. You do get some thrombotic thrombocytopenia purpura. That has been reported, but not to the same extent that we saw with diclodipine. And really, the reason this is used is it has a better side effect profile. We didn't see the same effects, and we see a lot of people on Plavix. The biggest concern with Plavix and diclodipine, big concerns is going to be excessive bleeding. Okay. All right. So let's do this. We have 4 more questions. So let's have you take the last 4 questions. So Marissa, have you got the poll there? And if she's got the poll ready, we'll do that. So I have almost a quarter till the hour. So take this and take your break, and then we will come back at 5 after the hour. And then we're going to, we'll go for about another 30 to 40 minutes, and I'll give you your 10 post-test questions. So, and meanwhile, Kirsten, I'll see if I can find an answer to your question. So I'm going to go to mute, and at 5 after, so take the test, 5 after the hour, we'll come back and continue on. Okay, guys. Kirsten, to answer your questions, apparently there have been some studies that show that it reduces, it's not just the colon polyps, but colon cancer. And the mechanism that they have proposed is that basically that by aspirin affecting the platelets, apparently platelets also carry a protein called the oncoprotein. And what happens is the aspirin inhibits the oncoprotein, and that changes the expression of the genes in the human body. And the oncoprotein basically controls the life and death cycle of cells. So basically, that would supposedly interfere with cancer forming there. So there's I think it was a study that came out in 2015 that first reported that. There have been a couple of other studies, but interestingly, what they did say was that there was that it hasn't caught on yet. So there's still, although there's theory behind it, that not everybody has gone on picked up on that. So anyway, I had not heard that before, but basically the aspirin indirectly inhibits the oncoprotein, and that is that oncoprotein helps regulate the malignant cells, and by inhibiting the oncoprotein, you inhibit the formation. So, good question. I had not heard that before. Okay, so we're going to. Oh, let me go ahead and give you the answers to these questions that you guys just finished. So, question number 5: oral administration of cyanocobalamin, which we actually ended up talking about yesterday, was the preferred treatment of pernicious anemia. Actually, we talked about it this morning, I think. And the correct answer is true. It's false. The reason that's false is because if somebody has pernicious anemia, they can't take the drug orally. So cyanocobalamin, which is B12, is in fact the preferred treatment, but it has to be parenterally. Question number 6: which of the following is contraindicated in pregnancy? You had heparin, low molecular weight heparin, warfarin, and C, all of the above. The correct answer is C, warfarin. Heparin and low molecular weight heparin is not contraindicated, and we could use those as an anticoagulant. Question number 7: evidence of warfarin toxicity could include, I listed epistaxis, hematuria, and GI bleeding. The correct answer is D. Epistaxis is nose bleeding. Hematuria is blood in your urine, and GI bleeding is bleeding from the GI tract. So the correct answer is all of the above. And 8, thrombocytopenia would be best monitored by ordering A, INR, or B, a CBC. The correct answer would be B. The thrombocytopenia, you're looking at a reduction, although the INR might go up. The CBC would actually give you a complete blood count, would actually tell you that the platelet numbers are down, and so that would be the correct answer is B, which is CBC. Okay, and we'll post those answers. Marissa, you can post all of the answers to these questions late this evening or in the morning, either one. The first 4, Arnold, you're talking about the first 4 this morning. So question number 1, stimulation of beta-1 receptors that would elevate heart rate, which is the correct answer is B. Question number 2, blockade of which receptor is used to decrease gastric acid secretion? Correct answer is B, which is histamine 2 receptors. Question number 3, histamine is found in which type of cell? And the correct answer is D, which is mast cells. And question number 4, which drug would be more likely to interfere with the metabolism of other drugs? The correct answer is B as in boy, which is cimetidine. Okay. All right. Now, there's a few of these drugs that we're going to move through a little bit quick because you're not going to see them a lot. I just want you to be aware of them. One is the fibrinolytics. I told you earlier today that when a clot forms, the platelets sort of clump together to seal the, where the hole is or where the bleed is occurring. And then what happens is there's these fibrin structures that get laid down that sort of act as scaffolding that help platelets to attach. So when after a clot is formed, the body normally will break it down by, the body has what is called fibrinolytics, which basically go in and lyse or dissolve this scaffolding and helps the clot to resolve. Well, one of the things that we can do is we found that if a clot forms like in a thrombus, which is abnormal, one of the things that we will do is we can use fibrinolytic drugs, which basically break down these fibrin factors. These are often referred to as clot busters. So they use them, you have to use them fairly quickly, but they will use them. They have to be given intra-arterially or right to the clot. So they lyse or they break up the thrombi by basically catalyzing or stimulation the formation of serine protease plasmin from Zymogen. So you don't need to know. All you need to know is they lyse or break down the clot. Many of these are enzymes. We have streptokinase, tissue plasmagen activator, urokinase, alteplase, retiplase, tenecteplase. Streptokinase is going to be our sort of prototype drug. So they create a lytic state. They break down these clots, and by breaking down the clots, it sort of dissolves the clots. Streptokinase actually is divided. The reason it's named this, it's an enzyme, actually a protein that's synthesized by Streptococci bacteria. And so what it does is it combines with proactivator plasminogen and therefore breaks up these fibrin factors. Urokinase, an enzyme, it's called uro because it comes from the kidney, think of urine. It's from a human enzyme, and it breaks them down with a slightly different mechanism, but very similar. And so what we use these for is person gets a pulmonary emboli, we need to break it up. If they get a deep vein thrombosis, or sometimes when they have a heart attack, the idea is we give these fibrinolytics, the fibrinolytics get in, dissolve the clot, and restore blood flow. We also have a couple of other drugs that are used as anticoagulants, sort of in the generic miscellaneous. We have a couple of drugs. We're going to use RioPro, which is abixiximab. These actually block receptors on the platelets. There's a platelet glycoprotein 2B3A, which are on the platelet, and it's how the platelets sort of stick together. And so that's sort of how the platelet sticks to the fibrin and to the platelets. And so what it does is by blocking these receptors, all you need to be aware of is that it just simply prevents the platelets from aggregating. And if the platelets don't aggregate, you don't form a clot. And then the other drugs that we see used, they're actually derivatives from leech. So a lot of animals that bite us, mosquitoes and leeches and things like that, even vampire bats, what they do when they're trying to feed on blood is a lot of times they secrete in their saliva an anticoagulant. And that's exactly what leeches do, is that leeches, when they attach, their saliva basically generates has got an anticoagulant in it. So what that does is it allows the blood to flow freely so they can feed. The vampire bat does the same thing. Mosquitoes do the same thing. So the protein basically that the leech forms is called hirudin. And basically it inhibits thrombin. And the idea is, we still see, by the way, there are, in fact, one of my students a couple of 2 or 3 weeks ago told me they actually were at the hospital and dispensed medicinal leeches. They use those to try to, when they are doing reattaching fingers or some of those type things, they basically are going to use those so that there's no coagulation and the blood vessels can grow. So what these drugs do is they basically inhibit thrombin, which results in anticoagulation. And the thing about these, the nice thing about them is they don't really affect platelet function. They just prevent platelets from coagulating. Again, these are used primarily from a standpoint of as an anticoagulant. We've got a few of them. Lepirudin. This is a recombinant inhibitor that comes from the leech. Now, the big thing about these thrombin inhibitors, they are the treatment for thrombocytopenia. So if the heparin, produces this, they will basically reverse the thrombocytopenia. Um, they have to be given parenterally because they have a very short half-life. And we really have to be careful because if a person has renal insufficiency, they can't break it down and it can accumulate. So we have to be very, very careful with using those, making sure it's the right patient. We also have one called bivalirudin. They will use these not only for treatment of thrombocytopenia purpura, but they also can use them to prevent clotting that occurs maybe to trauma. So they use them when they're going to do angioplasty. Argatroban, another one that's used for the heparin-induced thrombocytopenia. The biggest thing about argatroban is that it will interfere with the INR test. So if we use the argatroban and we're going to move from heparin to warfarin, we have to be aware of this. Now, what happens if we get too much bleeding? All right, so the previous things we've talked about have been primarily anticoagulants. So what do we do if we get excessive bleeding? And one of the things that we can use is vitamin K. As I mentioned earlier, we can use the vitamin K to reverse warfarin. Things we can give is we can actually use plasma fractions, which have the anticoagulant or the coagulant factors in them, so we can replace those. We can use things that inhibit the breakdown of the clot. So there's like aminocaproic acid is a fibrinolytic inhibitor, so that can reverse that. And then we can inhibit serine protease inhibitors. These are drugs that are used primarily to reverse the actions of the of anticoagulants. Probably our biggest one that we worry about is going to be warfarin. And so vitamin K, as most of you know, basically the source of it is green leafy vegetables. It's also synthesized by bacteria in your colon. So if someone is on warfarin, we have to educate them with regard to if they eat too much leafy vegetables, that can elevate their vitamin K, which can then interfere with warfarin's actions. We also know that sometimes antibiotics can interfere with bacteria in the colon, so that could sometimes change the vitamin K concentrations. But typically, we're going to see vitamin K used to reverse the effects of warfarin. We have an oral vitamin K. We have an injection vitamin K. If we give it IV, that has to be done very slow. There have been some reports of people that have had difficulty breathing if it's been injected as a bolus. And actually, a few people have died. So you've got to be very careful with that. But basically, we're going to give it, we're not going to give it sub-Q. The absorption is too erratic. And so we do use vitamin K to basically reverse the effects of warfarin. So if someone is bleeding too much due to an overdose of warfarin, vitamin K is the antidote. There is a vitamin K3. It's water soluble, but it's not used therapeutically. We use vitamin K1. As I said, these plasma fractions can be used when people take blood. The blood banks can isolate them, so you get these concentrated plasma fractions. So, for example, people that are hemophiliacs, one form of hemophilia, they're deficient of clotting factor 8. So we can actually give clotting factor 8 to make up for that deficiency. Christmas disease is another form of hemophilia. Those individuals are deficient in factor 9, so we can actually give factor 9. And then we can also, there is a cryoprecipitate, which basically has fibrinogen in it, and that can be given. So in some cases, they may be giving different fractions with different components, and they're replacing or, when some of these anticoagulants have interfered with or depleted these factors, they then can replace those. There is a drug called dipyridamole that used to be used a long time ago. We see its use it's still used today. You will see it in combination. It works differently from the other ones. What it will do is basically it inhibits the uptake of adenosine and also inhibits cyclic GMP phosphodiesterase activity. Both of those actions are associated with anticoagulant or antiplatelet effects. When dipyridamole first came out, they thought it would be better, but it turns out it's not effective when used as monotherapy. So they typically will mix it with aspirin, and they will use it as a prophylactic for stroke. They may mix it with warfarin to use as thromboemboli to prevent those from occurring in patients that have heart valves. There is a lot fewer doctors that use it. I've even heard some doctors say they ought to take it all and throw it in the ocean. It's no good. But there's still a few docs that will use this, but only in combination with other drugs. There is another drug called celestazol. It's a phosphodiesterase inhibitor. And this one is used more for intermittent claudication. Claudication is for people that have clotting, a poor blood supply down into their legs. So they get the cramping in the muscles. And this one basically inhibits clots and from forming in the legs and forming ischemia. So this one is another antiplatelet drug. Now, the last group of drugs I really want to cover is these new ones. These are the ones that basically are all over the news and, or I should say, the advertising and so forth. And the three are Pradaxa, Xarelto, and Eliquis. Okay, these are all we refer to these. They are now the new term that they use are called NOACs. Let me put that for you. It's NOAC. That's the acronym that people use, which stands for New Oral Anticoagulants. The big thing is when you look, in fact, one of the videos that I've got for you guys to look at talks about the emergence of these drugs here. So one of the big problems was warfarin was really our go-to drug, but as we talked about today, is it has a lot of problems. So these drugs here were really the result of trying to find a better or a replacement for warfarin. The big thing is these are not working through vitamin K. That was one of the problems with warfarin because that could be affected by diet. So these are independent of the vitamin K pathway. The other thing is, remember, warfarin took a little while to kick on. So these supposedly kick in faster. They have a faster onset. Because they're not affecting the vitamin K pathway, we don't have food-drug interactions. And I've got the last thing is a lot of people have promoted these drugs in that you don't have to monitor like you did with warfarin. And I'm not sure that's exactly true because literally the point becomes is that these drugs, one of the things that we see is actually that bleeding can be an issue. And so one of the things that's a point of controversy is that monitoring may be necessary in certain patients. So that is a question mark. But also people think that there's less of an issue of bleeding, and that's not true either. In fact, as we go through these, so these are all independent of vitamin K. So let's talk about dabigatran. This was the first oral direct thrombin inhibitor. It's approved by the FDA. What it does, it's actually a prodrug. So what happens is that there are esterases that are in your plasma and liver. These are non-specific. Esterases are sort of like acetylcholinesterases, or they break down acetylcholine. But what happens is when these go through your blood and your liver, they get converted to the active component. And what the active component then does is it will bind to the free and clot-bound thrombin. And so that it's a competitive binder. And so that's how it produces its mechanism of action. So we use it. It's been approved for prevention of stroke and prevention of embolism in patients with atrial fibrillation. Many of these drugs were promoted for treatment of atrial fib patients. It also is used for to prevent thromboembolism of the veins. And so here's the interesting thing. If you look at these drugs, what they saw was the studies suggested that the rates of major bleeding episodes was similar to warfarin. Notice they didn't say it was better than warfarin, okay? So you don't have to prove your drug is better than what's on the market. But these drugs were sort of touted and sort of people thought they were going to have a better safety profile. But what we saw is when you look at it is the clinical studies showed that the rates of major GI bleeds in particular was not any worse than warfarin. So that's big difference than being that it's better than warfarin. They weren't any worse than warfarin, okay? But they did say the incidence of all bleeding events was lower than warfarin. So the FDA approved it on that. So it wasn't worse than warfarin, but they said that when you consider all bleeds, all bleeding events, then it was warfarin. And people have criticized really this as to, is it really better than warfarin? Now, it's not vitamin K, so there's some advantages there still. But the question is that they're really sort of were touted as being safer, and they may not necessarily be safer. There's still the potential for bleeds, and people sometimes think that the potential for bleeds isn't as bad. About 80% of this is excreted through the kidneys, so you've got to be careful with patients that have renal impairment. One of the problems is that if you had, do you need to monitor this? Do you need to monitor? Is there some way of monitoring dabigatran? The side effects, number one, is excessive bleeding. What you saw when the clinical trials, there was actually a higher rate of GI bleeds than warfarin at 150 milligrams, but the FDA concluded that the rate of bleeding was not higher than warfarin, and bleeds were likely secondary to underreporting of the bleeding events that were associated with warfarin. So they're saying it was an artifact. That's a point of contention right now. Another thing about this is that people have complained of severe dyspepsia, a sour stomach, or indigestion, to the point that some patients say it's not tolerable and they discontinue. We think the evidence suggests that the severe dyspepsia is not due to the drug itself. It's actually due to the formulation. They use what is called a tartaric core, which is necessary to create a low pH so that it can be absorbed. So it may be the formulation, and what we might see down the road is someone may come up with a different formulation that doesn't produce the dyspepsia. On all of the new anticoagulants, we do have a black box warning that says that there is an increase of risk of thrombotic event and stroke when discontinuing the drug. So basically, if you're going to take them off the drug, make sure you put them on another anticoagulant. They also have the warning that if somebody's undergoing spinal epidural anesthesia, which we see done fairly commonly, there's a chance that if people are on this drug that they can get a hematoma. And so that needs to be a concern. So that hematoma can actually is a bleed into the tissues and can cause pressure on the spinal cord or on the spinal nerves. Another one of these new drugs is rivaroxaban. This one acts on factor Xa. It's a direct inhibitor. It's orally effective. And what it does is it binds to factor Xa, and it affects both the free and platelet-bound factor Xa. So it's acting on a slightly different site. Used for about the same situations: prevention of venous thromboembolism, prevention of stroke, and embolism in patients with AFib. So again, same indications. We have seen some mild hepatic impairment. They doesn't require dosage, but they don't recommend it in patients that may have moderate to severe liver impairment, as indicated by their liver function enzymes. The major side effects are bleeding. That's the number one thing, but we have seen patients complain of musculoskeletal pain, some itching and blisters. A few patients have basically had episodes of syncope. So, but again, the major concern is bleeds. And then the last one, apixaban, also acts on factor Xa, and selective and reversible inhibitor, use it for the same indications. And again, its main thing is bleeding. There have been a few more patients that have shown syncope, drug rashes, and some anaphylactic reactions. Those are very, very rare. But with all three of these drugs, there is a concern that bleeds can be a problem. Now, one of the things that came up, if you compare this table here you can see the warfarin is in the first column. And when you look at these others, none of these are interfering. That factor, that should be factor 2A. It looks, I think it came out as an I. But they're acting on either factor 2 or factor 10. So they act through a different mechanism than warfarin. Notice that warfarin, you had a high protein binding. Dabigatran, you don't have that protein binding, but you do see it with rivaroxaban and apixaban. So apixaban is like 87%, but that's still pretty up there. The metabolism, warfarin goes through a number of enzymes, whereas these others, 3A4 is going to be a consideration. Warfarin has about a 36 to 40 hour half-life. What we see is a shorter half-life with these other drugs. Elimination is there. Now, go down to monitoring. With warfarin, we have to use INR. With the new oral anticoagulants, they say that it's not needed. That is a point of contention. There are people that say that if you're going to use an oral anticoagulant and bleeding is a concern, you need to be able to monitor that. And the INR is a question of whether it is an appropriate monitor for these new oral anticoagulant drugs. This is another thing, is whereas with warfarin we had vitamin K, but until recently we did not have an antidote for these three drugs. So if you got excessive bleeding, really the only thing you could do is basically try to discontinue the drug and then support by replacing the blood, okay? So that the fact about whether they need to be monitored is a big concern. And more importantly, until recently, there was the concern of we don't have an antidote for this. So what occurred just recently, we did get an antidote, which I'm going to show you in a minute. But the other thing is that when monitoring, the INR is what we use for warfarin. Some people have argued the INR is not the best test. It is not as sensitive and accurate. So for these new oral anticoagulants, they have what is called ECT. This is referred to the Ikarin clotting time. And what this is it actually generates mesothrombin. And by generating that, it gives you a measure of the activity of these direct thrombin inhibitors. The Ikarin basically comes from snake venom. A lot of snake venoms, they produce they actually produce a lot of effects on the coagulation system. And so what they do is they add ascarin to plasma to see how long it takes for the clot to form. So there's a question of whether these new tests, if the INR is the best measurement for it. Now, if you summarize these new oral anticoagulants, what we see is basically they really aren't superior to warfarin in efficacy. Many people still say warfarin is the best drug, and if it's monitored correctly, even though it's got a narrow therapeutic index, it is better. One of the things, if patients have renal or kidney problems, many people don't think that the patients are good candidates for those agents, but I bet you there will be people that will be used because these are the new, sexier type drugs. So they can come into things like there's recommendations if a person's having a hard time with being compliant, they can use rivaroxaban because you can get away with once a day dosage. If person already has some GI, GERD, dyspepsia, ulcers, you don't want to use dabigatran. And we see that the apixaban may have a lower. So these are some things that have come out with regard to these agents. Now, this is sort of the last point I'm going to make, is that one of the big concerns was how do you reverse these new oral anticoagulants since they're not vitamin K? If we get a severe bleed, what do we do? So prior to 2018, last year, we didn't have a reversal agent. And what we saw was this increased use of these new drugs when they came out. Everybody was jumping on the bandwagon. We saw there was an increase in the incidence of hospitalizations and death due to bleeding with these agents. In this one article, they said there were 117,000 hospital admissions and 2,000 bleeding-related deaths per month with these new drugs. That's pretty significant. And the question was, when we get these bleeds, how to reverse them. So what happened in 2018, a drug called Andexxa was actually approved. And what it does, it works on the factor 10A inhibitors. What this one is, it's actually a recombinant modified factor 10A molecule. And so what it's going to do is these anticoagulants bind to the ones that bind to 10A. What it's going to do is bind to that and inhibit that factor 10A. There is a black box warning about that. You can get some arterial and venous thromboembolic events. You can get ischemic events such as myocardial infarction and strokes, cardiac arrest, and sudden death. So one of the things is when you reverse the oral anticoagulant, you may cause coagulation. But it wasn't until 2018 that we got a factor 10A inhibitor that was used that could reverse this. All right. So that sort of concludes what I had to cover today. We have left is your, Marissa has got 3 video links I'd like for you guys to look at them. One is how it shows an animation showing how heparin works. One is showing how the warfarin works, and there's about a 5-minute video showing the evolution of these anticoagulants, which is sort of interesting. And then there's a video showing about this thrombotic thrombocytopenia, purpura, just to show you what happens when that occurs. So what we've got left to do is basically the post-test. So Marissa, if you want to give the post-test, what we'll do is we'll post the answers to the post-test in the next day or so. Okay, so then you can go back and look. Again, you're not getting graded on the post-test, so it's not gonna factor in, but you are getting credit just like with these other tests. You do get, you do have to take them, and it's part of the requirement to get this. Okay, does anybody have any questions? And Eddie, the thing about it is some of these questions are going to be very similar to what I'm going to ask you in there. So that one thing that will help is I try to make those questions very similar. So sometimes you may get a rewording of some of these questions. So it will help you study there. And by giving you the test, you can sort of see what's there. The next time we meet, we're going to be talking about cardiovascular, I think, and pulmonary drugs. So that will be the next thing, and we'll have the slides up. I will try to have the test up and ready or submitted to the proctors before Wednesday, so they can post it on Wednesday. And then don't forget, there will be a between week assignment that you guys need to complete. It'll be due next weekend, I think, on by Sunday. So again, it'll be 2 or 3 questions and a very short thing for you guys to look at. So Marissa, if you want to go ahead and give them the post-test, I'm going to sign off, guys. I hope you have a great week. You guys have done really well with the test. I've been really pleased, and Marissa's already got it on Moodle. So the between week assignments I will try to have up by Wednesday, and it'll be up through Wednesday through that Sunday. Okay. All right, guys. Y'all have a great week. And Marissa, thank you so much for all that you've done. Been a great help, and good luck. See you guys later.